Hi, everybody. My pleasure to present at the Cannabis Congress. I'm Dr. Mikhail Misha Kogan, Associate Professor of Medicine at George Washington University and Medical Director of the GW Center for Integrative Medicine. I'm a geriatrician by training and a palliative care doc, and I have been recommending medical cannabis for quite some time, and probably to over 3,000 patients at this point. A few disclosures. I am a paid consultant for a number of companies. I have a number of slides co-developed with me by Donald Abrams, who's one of my mentors, as well as Leslie Mendoza-Temple. I also want to thank Society of Cannabis Clinicians. For those interested, the full course in much greater detail than this particular presentation is available on the Society of Cannabis Clinician website. And I do collect royalties from the books listed here, and I also co-own a practice where I recommend medical cannabis to my patients. Objectives is to review critical need for effective non-pharmacological treatments for a variety of common illnesses of older adults, review changes in the endocannabinoid system as they relate to aging, and develop clinical plan for applying targeted exogenous cannabinoids for older adults for specific clinical conditions. Successful aging is far beyond being healthy and vibrant. It is rectifying internal conflicts, paradoxes, and redefining life's meaning. This is a quote from my 2017 Integrative Geriatrics textbook with Oxford University Press. And it highlights the critical aspect of aging, that it's not just about not having medical problems. It's really about functionality. It's really about finding and refinding meaning in life at times when maybe the professional career is ending. There are multiple losses that are commonly associated with aging, and living with all this and continuing living and continuing to stay happy and engaged is really is the core aspect of aging. So let's see how the cannabis fits into this. The adults over age 65 is actually the fastest growing population in the world. I'm super psyched that I'm presenting here in Costa Rica because, in a way, Costa Rica is a fascinating country for studying aging. Costa Rica is one of the one of the blue zones. The area of Costa Rica called Nicoya is famous for a long-lived people. Those who can live over age of 100. And it's thought to be related to specifics, and we'll talk a little bit about this in a couple of slides. What's also very interesting that the longevity in Costa Rica, or life expectancy, as it defined, crossed age of 80, and it's longer than in the United States, despite the fact that Costa Rica spends fraction on healthcare compared to the US. And so the key question is, why is that? And I think it is important to address this question, as you'll see what's dragging down life expectancy in the US actually is related to this topic very heavily. So as I mentioned, Nicoya in Costa Rica is a blue zone. So it's one of originally 5 blue zones defined, and it defined by the frequency of those who make over 100. So it's a record zones where there are more people living over 100 compared to the rest of the world. Of course, some of the unique features of Nicoya, just like the rest of the Costa Rica, is Pura Vida, and specifically Nicoya Plan de Vida, reason to continue living no matter what age you are. It's also thought to have a very high percent of minerals in drinking water. That's one of the important features. And it's not just magnesium and calcium, but also things like lithium and others. And I think it's very important that traditionally in Costa Rica, in Nicoya region, but also in lots of other blue zones, especially in Sardinia and also in Icaria, which is a small island off the Greece, mainland Greece, that the food is really considered medicine, and there are a variety of medicinal plants in personal gardens. And the importance of this is really cannot be understated. The capacity to have beneficial plants growing in your backyard that you can use for common conditions significantly decreases chances of consuming medications that are not needed. So, for example, those of you who have medicinal gardens and using the plants for common colds or any simple conditions, doing this, and because you do this, then you don't take specific medications. And even simple medications like acetaminophen or ibuprofen, while may be quite benign, they're actually causing a lot of problems. So in United States, the third leading cause of death is medications. And we're not talking about just some dangerous medications like opioids, narcotics, but even Tylenol. Tylenol or acetaminophen kills hundreds of people every year in the United States alone. And so there's a very high priority to deprescribe what we say or decrease amount of medication prescription simply because we know that the impact on mortality is quite high. Lucky for Costa Rica, that issue is not really present. As you can see from this slide, none of the top 10 causes of death are related to the correct or incorrect prescription medications. And that's, of course, speaks strongly to the fact that simply population is healthier, and also it relies on other methods, including those plants in the backyard. And I think in the future, having cannabis as yet another plant in the backyard and in pharmacies actually is a critical. And as you'll see through the rest of the presentation, there are very significant amount of evidence showing that cannabis is an exit drug from a variety of medications. How does the cannabis fits here? And I hope that by the end of this lecture, I'll be able to convince you that cannabis is one of the safest medications that we can offer to our older adults. And that actually doesn't even relate to how old they are, what medications they take, and what comorbidities they have. Cannabis can effectively treat chronic pain. It can be effectively used for multiple conditions related to frailty. So as an appetite stimulation, as a source of vitamins, and as anti-inflammatory. It's very effective for treating dementia-related behavioral disturbances such as agitation, anxiety. It is also very effective for insomnia as well as disturbed cardiac rhythm. And most of all, it dramatically decreases iatrogenic complications. So we are talking about decrease in overall total medications prescribed, and as such, decrease in total mortality and related comorbidities and related complications. It is one of the safest and cost-effective treatments. In contrast to most prescription medications, cannabis is associated with improved quality of life, not worsened. And again, we'll see the evidence for that in just a few minutes. And then cannabis is by far the best palliative care tool we can offer for those of our patients who are in the last months of their living, especially those dying with cancer and advanced Alzheimer's disease. In the United States of America, cannabis use in those over age of 65 is the fastest growing population. So you can see that in just span of 10 years, there has been a massive increase, and maybe the total percent use is low, but if you look at the actual absolute increase of 2.5%, but it represents relative increase of several folds. So let's talk a little bit about what changes in endocannabinoid system, or ECS, as we get older. Well, there are a few critical changes. So first of all, there's a decrease in CB1 receptors and also coupling of G protein in aging brain. And this is a pretty strongly supported, not just in animals, but also in human data. By age of 65, the density of the receptors is down by approximately 50%. Similarly, anandamide, which is peaks around the onset of puberty, gradually decreases with age, and there's a more than 50% decrease total in age of over 65. If we take an animal, for example, mice, and we delete the CB1 receptor, this tends to cause a rapid onset Alzheimer's disease-like process with hallmark of loss of volume in part of the brain called hippocampus. And this appears to be a uniquely tissue-specific aspect. As you will see through the further presentation, when we talk about clinically about Alzheimer's, I'm one of the probably a handful of people who do believe that at some point in the future, we will see cannabis becoming a part of the standard Alzheimer's treatment protocols. I don't think I'm in a position yet to discuss specifics of which protocols should it be, but I'm pretty certain that we are going to witness a pretty significant both pharmaceutical and also medical cannabis interest in this arena. And not only based on this data, but I'll show you some other specific data later in presentation. It's critically to note that most of, if not all, prior studies on side effects of THCs on the brain in humans were done on younger populations. And what we seemingly seeing from the animal data is that in older animals, the THC appears to boost cognition and not decrease it. So, it's yet another paradox of cannabis, just like a dosing paradox when you have bimodal distribution, meaning that at low doses there's no effect, but at the very high doses there's also maybe no effect, and you're really looking for that particular specific targeted zone of the therapeutic application. Kind of similar, there's this bimodal age-related distribution where at young age you have one impact and in older age you actually have a different impact. A few additional points. Cannabinoids do stimulate autophagy. This is quite important, especially for those interested in the basic principles of aging as well as longevity. Correct autophagy is critical for longevity. We do know that when the clearing of the debris or ineffective cells, which is what autophagy is, not done appropriately, the aging is accelerated. So can exogenous cannabinoids play a role in slowing down aging? I think that's to be determined, but it's a very intriguing principle since we do observe in not just petri dishes in vitro, but also in animal models that seems to be true. Now, how this will translate to clinical information, I think it's yet to be determined. And the cannabinoids are, of course, known to be an excellent signaling molecule for short-range cell-to-cell communication and enhancing synaptic communication. Again, probably that's why the neuroprotective and anti-inflammatory or anti-inflammaging changes are observed. And inhibition of anandamide degradation appears to stimulate adult hippocampal neurogenesis, but inhibition reduces it. So, that's yet another experimental model that demonstrates a quite significant potential for a future of Alzheimer's disease. And also just a future of a decreased or progressive expected memory decline with aging. There is some degree of expected memory decline, even if we don't call it an Alzheimer's disease. So, back in 2017, I edited this book, and I coined this term, Integrative Geriatrics. And since I've been on this path to try to enlighten the world that we really have to take care of our older adults a little differently. I think we need to really prescribe, we need to center treatments on non-pharmacological approaches first, and only if those fail, move to medications and surgeries. And the cannabis fits here perfectly because it's not only plant-based, but it's also a highly patient-centered. Cannabis can be administered in so many different ways. Patients can control the administration because they can titrate the doses very precisely. They can also improve their own quality of life by taking it. And that's also really essential, especially for those who have multiple medical problems and have complex symptoms and require symptom management. In just recently, there was a really interesting publication coming out of Professor Raphael Machulam's research team showing that in over almost 3,000 older adults in Israel, those who had a chronic pain and were administered cannabis. When assessment was done, it was shown that the cannabis was a very effective pain treatment. In fact, it was probably more effective than any other existing treatment this particular group of patients were receiving. It's a very high quality study, and even though it was not necessarily randomized, but just by the sheer number of total patients, it's a pretty important, and it's the only data we have that specifically addresses the question, does cannabis work for pain in older adults? And it appears that the answer is strongly yes. So what you can see here, that at the end of 6 months in this light blue versus dark blues before the treatment, there was doubling amount of patients with no pain, and there was almost 100% decrease in patients with severe pain, so 10 out of 10 pain here on the right. You see that at the beginning there were 254 patients, but at the end there was only 12. Personally, I do not have any other tool in my practice to offer to my patients to have over 90% chance of basically removing severe pain. And even very strong narcotic or opioid medications do not achieve such a degree of efficacy. Now, of course, it's not a controlled study, as I mentioned, so it needs to be looked with some caution, but nonetheless, just the degree of effect is very significant. And also, the perception of general effect, most of the patient had significant or at least a moderate improvement, and very minor proportion had slight or no change. So let's talk about particular conditions. So this is a bit more practical part of this talk. So we're going to talk about how do we apply cannabinoids for chronic pain in older adults. We'll talk about insomnia, and then we'll talk about what we call a neurobehavioral changes in Alzheimer's disease. So chronic pain in adults is extremely common. It's probably the most common condition. It's not only related to age-related arthritis, it's simply related to the fact that with aging, there are a variety of other conditions that are common. Typically, pain in older adults is related to some other chronic state, whether it is as arthritis, as I mentioned, or rheumatologic conditions, or changes in the spine curvature, or musculoskeletal trauma accumulated over the years, etc. Generally speaking, certain modalities that we know very effective for chronic pain, such as acupuncture, massage, and a variety of body manipulations like chiropractic and osteopathy, are pretty expensive. They require time. They're often not covered by insurances. And another really important specific point to older adults is that doses of medical cannabis are often significantly lower compared to younger, and that makes a cost much lower. And I think that's one of the really important factors, especially in the United States. For now, cannabis can be pretty expensive, and I hope that Costa Rica does learn from this and makes cannabis commercially much lower priced to be affordable for the entire population. But of course, the main reason I'm coming back to the same, and I will keep coming back to this, is the fact that it decreases amount of polypharmacy. You will see from data coming in the next slides that it's actually really important. When cannabis is started, we generally seeing decrease in variety of use of chronic pain pills, whether they're narcotics or other medications, or even medications like Motrin or ibuprofen or acetaminophen. And it's pretty clear, as I said already before, cannabis appears to be safer than even NSAIDs, such as ibuprofen. So here's a case study of my patient. It's a 64-year-old woman who presented with severe back pain and constipation due to metastasis of the breast cancer to the spine. She did not want to keep increasing her narcotics. In fact, the reason she came to see me is because she didn't want to continue to work with oncologists, and she was not interested in enrolling in hospice because she wanted to have medication-free options explored first. She's a fully working journalist, independent, still ambulatory. She found our clinic through just Google search and was hoping for a pretty specific treatment called IV mistletoe. I'm not going to go into that. It's not related to this case, but as part of the conversation with her at the initial presentation, I offered her medical cannabis for pain. She absolutely refused any oral or inhaled route or any route that would make her intoxicated, because she needed to continue working and was very leery of being intoxicated at any point during the day or the night. So what we decided to do is to put her on a low dose rectal suppositories. I often start any pain regimen, and in fact, I often start a lot of different conditions with this 1-to-1, what we often call as a balanced CBD or THC to CBD ratio, and then titrate it up pretty quickly over 2 weeks to the dose of 25 milligrams of suppositories twice daily. She weaned herself off of oxycodone in 4 weeks. Constipation fully resolved after she went off oxycodone, and her pain got also fully controlled in that time. And despite the slow progression, she lived for almost 2.5 more years and had a quite comfortable life until the end. Here's another case. This case is more striking. It underlies the importance of understanding how to apply cannabinoids, and really highlights the point of misunderstanding among a lot of prescribers, a lot of physicians. Now, this case is relatively old by now. It's been presented actually at several different meetings, and it's probably at this point 7 or 8 years old. So some points from this case are no longer as relevant, thank God. You'll see that in a second. So this is patient presented to the hospital. She was admitted to intensive care unit, ICU, with severe delirium. She was intubated, and the family was told that the prognosis is very poor because it wasn't understood why she had severe delirium. She didn't have any infectious etiology to be treated. Right on admission, the geriatric service was consulted, and upon very detailed investigation of records, talking to the family and looking for outside of hospital records, it was noted that approximately 7 days before admission, one of the common pain medication called gabapentin was increased to 300 milligrams every 8 hours from 200 milligrams every 8 hours. So the mistake here was, or not a mistake, but an anticipated side effect was that the patient with chronic renal insufficiency can accumulate this drug, and the patient wasn't monitored, wasn't carefully assessed. Moreover, the problem skipped the radar of ICU attending as well as emergency room attending, and only the geriatrician, myself, on a consult was able to determine this. And 24 hours after admission, the gabapentin level was still elevated. So one can only imagine what that level was right at the admission. So gabapentin was rapidly tapered down. You cannot just stop it quickly. It can cause seizures. And delirium slowly resolved. The patient actually shockingly returned completely to the normal cognitive function, which nobody expected. She was quite sick. Of course, her pain came back as she was as her cognitive function improved. So on discharge, she decided to quit. She wanted to see me as a doctor for consultation for chronic pain. So I recommended that she starts acupuncture. I also like to use combination of several vitamins for neuropathic pain, specifically alpha-lipoic acid, benfotiamine, and gamma-linoleic acid, or evening primrose oil. And I also recommended that she starts with a low-dose sublingual drops, cannabis drops, starting with just 1 milligram of THC equivalent, and then slowly going up until the pain is better controlled. So this is some of her sentences when she came back about 6 weeks after the initial visit. Well, I did get high a few times. It reminded me of my hippie years. But after a few weeks, I figured out how to dose it just right. I have no idea if supplements are doing anything, but acupuncture has been helpful. And here's the sentence that I want everybody to pay attention to, because I hear it all the time. I have to choose pot over acupuncture, because all these costs add up. And so you'll see through next cases, a particular case of insomnia, that the cost in particular this patient can be actually quite controlled compared to if the average acupuncture cost where we work in downtown District of Columbia, Washington, D.C. is about at least $100 each. The cannabis cost here could be less than $100 for the entire month. So the cost is significantly lower. And here, a patient asking me if I can write her a letter to help her for her insurance, medical insurance, Medicare, to pay for cannabis. Of course, that's not possible. And also, though, by the way, my primary care doctor wants to call him because he thinks that I should not use pot as it's very dangerous at my age. And he wants to put me on another medication, but I don't think so. So as I said, this is a case that was first seen, I've seen this patient more than 7 years ago, and this is when we still were getting this type of reaction. Oh, how can you give this old person the cannabis? The medication is safer. Now, of course, we know very clearly that's just not true. It is very clear that cannabis appears to be the safest option we can offer for this particular patient. And to prove that point, here's the chart of the cannabis toxicity and addiction compared to common other medications. So, for example, we don't have a gabapentin here, but we do have a pentobarbital, and then we have even simpler medications such as caffeine. And you can see that all of them appears to be significantly less safe. So on this x-axis, you're seeing the lethality versus active dose, and you can see that heroin would be the worst case scenario over here on the right, and then the marijuana, cannabis, as well as LSD and psilocybin appears to be the safest. Just a word about addiction at about 10% is a pretty well-known number. I do find that in older adults, I do not see any addiction, especially when I use balanced strains with CBD. So again, what's working one way for a younger brain is pretty clearly not working the same way for the older brain. But there are common geriatric side effects of cannabis, and some of them are pretty concerning. Dizziness, unfortunately, is the most common, and dizziness is a big problem because a lot of older adults are already dizzy from other things, whether it's medications or just other problems. Often the blood pressure fluctuates, can cause dizziness. Dry mouths, lethargy, weakness, all those are common. Also pay attention that the nausea is very common. I think that's actually quite important because there's always perception that cannabis can treat nausea, while that's of course very true, but it can also cause nausea, especially when the dose is high. There is no data to suggest really important side effects in older adults, and those are really false delirium, weight loss, worsened sleep, and worsened cognition. So really that's essential because this would be the type of side effects I would consider very concerning, and I would not recommend cannabis if they were to really be there, but they're not. And I think that's an important point. And really the main problem with older adults is the logistics of recommending a needed amount of follow-up, amount of conversations that are needed, and the costs. So those are probably most important. And most of the time when patients not able to get effective protocol in place, I find that it's not because it's really not working, but because they haven't really gotten to try the right products. They couldn't get card to get access, or they couldn't afford it, or a combination of some or all of the above. This is another study showing the importance of a combination of safety and efficacy. Again, this is neuropathic pain, the same case that we just talked about, similar pain. And what you're seeing here is a benefit to safety balance. And this is a compendium of data published by European Union expert panel. And you can see this blue is a benefit, and then the kind of this yellow or whatever that orange color is safety. So ibuprofen or Motrin is clearly quite safe at the score of 51, but actually not safer, less safe than CBD, but basically not effective at all for neuropathic pain. And for example, we can take fentanyl. Its benefits for chronic pain, for neuropathic pain, is very low at 11, and the safety is very bad. It's more than 2 times worse than for cannabis. But if you look at the THC and CBD balanced ratio, it seemingly becomes a winner. It has pretty high potency, pretty high safety profile at about 50. So it's just as safe as Motrin, basically. And it's pretty effective. Its effectiveness is at 21. So just to give a comparison, so gabapentin, which is the most common drug called Neurontin, trade name, is actually less effective than 1-to-1 ratio of THC to CBD. And the gabapentin is generally considered to be a first-line treatment for patients with neuropathic pain. That is that drug that this patient that I just presented, the 76-year-old woman, was taken. And so, as you can see, that the approach that I did 7 years ago is quite well evidenced as of 2021. This is another study highlighting efficacy and safety. So this is in America, Medicare Part D population is the patients over 65. So it's an insurance type of insurance that provides coverage for patients who are retired. And so in those patients who have this insurance, when the particular states were legalizing medical cannabis, there was a dramatic drop in the amount of pain pills patients were taking. Now, this is not prescriptions. This is an actual doses decrease. So there's a way to track the records, because when insurance pays for the prescriptions, that data can be collected. And so this is a very dramatic data. I mean, we're talking about almost 4 million fewer daily doses filled in at the pharmacies. And of course, you can think, well, does that translate to hardcore outcomes? And absolutely. What it translates to is to at least a 25% decrease in mortality related to the painkiller overdose. And if you look at this graph, what's really essential to understand here that when you look at the timeline, so this is over 6 years that the data was collected, it is very clear that with length of time, the mortality benefit increases. So by the fifth year, there was nearly 35% drop in the mortality. And it's a very dramatic impact. A third of all the deaths attributed to the opioids can be prevented just by allowing patients to have access to medical cannabis. So how do I recommend patients start treatment for chronic pain? Well, the standard mantra, and this is not just my mantra, it's a geriatric mantra, is start low, go slow. The only difference I added here is that start low, go slow, and deliver where it needs to go. Remember the case of the patient with the back pain, who I recommended suppositories. That is because for a low back pain, especially low back pain as it relates to metastases, suppositories make a lot of sense because they're delivering the medicine, the cannabis, pretty close to the target. It would be the same for peripheral neuropathy for some patients, where the topical can be a godsend, and it significantly decreases chances of any systemic side effects, although I have seen that when the very high doses are used, but that's very unusual, very atypical. So if the topical doesn't work, then of course you can proceed with sublingual or oral routes, but a lot of patients would still prefer inhaled. In older adults, I don't recommend inhaled unless the patient really wants to. And the reason for that is that we do know that the chronic obstructive pulmonary disease and chronic bronchitis can get exacerbated, and there's a higher chances of that for patients who use inhaled forms of cannabis. I decided to put a little bit about CBDa and CBG here in the talk, especially because CBDa is such an important add-on to our armamentarium, because we really need COX-2 inhibition for older adults, since all of the arthritic conditions, whether it's age-related osteoarthritis, wear and tear arthritis, or any rheumatologic arthritis, be it rheumatoid arthritis or lupus. All of those conditions can benefit from COX-2 inhibition, and the side effects are minimal. And more important, there's very minimum to no interactions with cytochrome P450 in contrast to a CBD. And CBD is not a very strong, actually, I don't think it has any COX-2 inhibition at all. And so you wouldn't really expect for arthritic pain CBD to be effective immediately. There's going to be an anti-inflammatory effect. And as such, there's going to be some benefit over a period of time. But usually that benefit is not as pronounced as with CBDA. Unfortunately, in my experience, the dose of CBDA needs to be pretty high. I don't see the benefits under 20 and 25 milligrams a day. Most patients probably need somewhere between 50 to 100 or even more. Just like other cannabinoids, CBDA half-life is such that you probably want to administer it 2 or 3 times a day. And this is my favorite agent to try to get my patients off of the NSAIDs. Ibuprofen is the most common one, especially because they're so toxic in the older adults population. And then CBG is I have less experience. It's something I've been only using for a few years and with my patients. I do find that for some patients, it's a very potent appetite stimulant, which can be very important for age-related frailty and weight loss. It also is a mild antidepressant, and it's very good to use that for patients who not only have pain, but also have this general dysthymia or demoralization. Pain can impact every sphere of life, especially the mood. And because it's a mild antidepressant, I tend to not give it after 5 o'clock at night because it can be a little bit stimulating and people can actually have a disrupted sleep. The dosing of CBG is much less. Patients can start with 5 to 10 milligrams twice a day. So let's switch to insomnia, which is a very common, highly prevalent condition. Upwards of half of all the older adults will experience some significant insomnia in their lifetime. General sleep efficacy starts decreasing after age of 60. And as I said, a very high proportion of patients over 65 develop actual clinical insomnia. And unfortunately, insomnia is not such a benign condition. It can increase, or it does increase, risk of a variety of problems, including Alzheimer's disease, heart disease, and actually overall mortality. And there's a massive cost to the healthcare and to the patients associated with insomnia, and not just because patients need to take medications, but because if they're still working, then the poor quality of sleep negatively impacts productivity at work. It's very poorly managed. Gold standard considered to be a cognitive behavioral therapy, but it's not often available, and it's also quite expensive. Melatonin is commonly recommended, but its efficacy is very mild. It's much better anti-inflammatory drug, to be honest with you, than a sleep inducer. And unfortunately, most of the patients over age of 65, if they complain about sleep problems, they end up on hypnotic agents such as zolpidem or Ambien. And unfortunately, all of those medications increase mortality by causing confusion, falls, fractures, and faster progression of multiple musculoskeletal problems. Cannabis, in my opinion, is the most effective treatment for chronic insomnia we have. Usually when patients come in with multiple problems, which they often do, insomnia is the first one I treat, mostly because the chances of benefit is high and it's pretty quick. It may take weeks to improve pain significantly, but it may take only a few days to get the sleep improved. And because of that, I often concentrate on sleep on the first visit before we tackle any other problems. And the dosing is described here. I tend to start very low, probably lower than needed, but that's because there are a lot of really sensitive older adults, and you don't want to overdose patients and then really have them not being able to try again because of the fear or because of the body's kind of just rejecting the whole idea. And of course, the watch out for capsules and edibles causing lethargy, but yet they could be the most effective because they last a lot longer. And I actually think that a lot of patients end up switching from sublingual ficos to capsules or edibles over time once they figure out their own personal dosing. So here's one of my patients, 66-year-old man who was sent to me from our sleep center. Patient brought over 1,000 pages of records, over 20 years of not being able to sleep for more than 4 hours a night, due to severe terrors and constant awakening. He had tried every existing medication. He has tried every existing treatment, including alternative treatments like acupuncture. Nothing worked. And he came on the multiple medications, as seen here. So just starting him on a very low dose of 3 milligrams of balanced ratio and titrating it upwards. In 4 weeks, he had a complete resolution of night terrors, now sleeping normally 7 to 8 hours. Effective dose 6 milligrams. And after 4 years of this regimen, now the dose is closer to 8 or 9 milligrams, but it's still highly effective. He was able to get off of one medication and tapered the dose of another one. And now, still 4 years later, he still sleeps normally. Here's another case that particularly highlights the cost. This is an older woman who developed severe sleep disturbances due to the cancer treatment of tamoxifen. This is not a medication that she can stop because she does need it to prevent recurrence of her cancer. She was sent to me by her primary care doctor after multiple falls thought to be related to the Benadryl or Ambien that she was taking for sleep. She's on Medicaid, so she's not able to really afford any expensive treatments. So her cost in District of Columbia, she was able to get a discounted card for $25. And then she uses approximately 5 milligrams of THC sublingually at bedtime. She's off of her medications in several months, and her total monthly expense is about $30. And just to compare that, now this patient does not have to pay $600 a month for her Ambien, but insurance does. And so just to kind of highlight that discrepancy in the cost. And this patient is still following with me. She's very happy. She's capable of paying this amount of about $1 a day. And prior to that, actually, she was often buying Benadryl out of pocket. Benadryl is usually out of pocket, although it can be prescribed and sometimes covered. So the last condition I'm going to discuss is agitation and anxiety as it relates to dementia. Now, why is it important? Well, unfortunately, Alzheimer's is a kind of a silent epidemic. We're seeing the numbers of total patients of Alzheimer's with Alzheimer's disease are rapidly growing across the entire world, not just in developed countries. And all of the patients with Alzheimer's disease later in the illness will develop these conditions, and they're poorly treated. They typically treated with antipsychotics. Those are very dangerous medications. Similarly to hypnotic agents, they increase mortality. They're all on the Beers list criteria, which is a list of medications that should be avoided in older adults. And all of the medical organizations recommend restricting the use of antipsychotics as much as possible. So what does that leave patients with? Well, there's not a lot of options. There's recommendations for music therapy and other things, but really cannabis seems to be critical here. We think that one of the main reasons why cannabis is so important here is that it appears that in patients with Alzheimer's disease, there's a rapid decrease in anandamide. And it's thought to be due to the fact that for whatever reason, fatty acid amide hydrolyse is increasing as the Alzheimer's is progressing. So this is depicted by this graph. So FAH goes up as anandamide decreases. So you have this distribution in reverse. And as anandamide drops, the chances of neurobehavioral problems starts to go up. And this is why the thought of using THC has been in geriatric circles for quite some time. Here's a patient of mine, a mother of our massage therapist, who was living in a group home. She had an advanced Alzheimer's disease, and she started having increased psychotic breakdown when she would scream very loudly in the middle of the night, wake up all the residents. And the director of the group home was actually threatening son to expel the mother because they couldn't really, it's a small house, they couldn't isolate her enough to decrease the sounds, the noise that she was making. So we didn't have a lot of choice. We didn't want to medicate her. So we ended up giving her CBD 25 milligram in a yogurt popsicle. So her son was preparing the popsicles at home. And also he was preparing the THC brownies as well at this particular dosing. And then the staff of the group home was keeping those foods basically in a separate place in the refrigerator for her, being labeled that this were this patient's particular medications. And so this patient had a dramatic improvement, and she stayed in this group home for over a year and then passed comfortably from just progression of her Alzheimer's disease. This is a little hard to see table, but the reason I wanted to put it here is that 2 years ago, Michelle Saxton and I have published this summary of the efficacy in palliative care, cannabis in palliative care. And Dr. Agarwal is, of course, the Sunil Agarwal is our main expert in the cannabis in palliative care, and he wrote several seminal papers describing the importance of use of cannabis for patients in end of life. Here I'm just summarizing it briefly, the most evidenced approaches, including the ones for advanced Alzheimer's disease and neuropsychiatric dementia-related symptoms. There are multiple cultural issues. Many older adults, at least in America, consider themselves hippies or older hippies, and so they may be quite familiar with cannabis. They've taken it earlier in life. So not being able to ask about it and normalize the conversation instead of positioning discussion when you talk about drugs, I often position the conversation when I talk about just the treatment options. And often I do that when I talk about exit drug strategy. So when I want patients to take less medications, I'll simply introduce the concept of cannabis and say, well, I think you should be doing it because I want you to get off of this, this, and that drug. And this is how we're going to do it. And so the takeaways from this talk are older adults generally over-medicated, and I hope Costa Rican population doesn't follow this route. I do hope that the country will approve cannabis and will figure out the safe and effective utilization for older adults. Medical cannabis is clearly effective for chronic pain, insomnia, and a number of other symptoms, and appears to be a getaway or an exit tool or a drug from other medications. And it most likely will improve quality of life of our older adults, regardless whether medications are decreased. And of course, don't forget geriatric mantra for medical cannabis: start low, go slow, and deliver where it needs to go. I want to put another plug for Society of Cannabis Clinicians. You can find this entire module on recommending cannabis for older adults on this website. And I hope you like this presentation, and I have a lot of the parts of this presentation written in my recent book published by Random House, a book called Medical Marijuana, and it's available in a variety of different formats. I hope you enjoyed the lecture. Thank you very much for inviting me, and have a wonderful day. Take care.